Hello, KMC University clients. My name is Dr. Richard Mason, and today we're going to be talking about lumbar disc herniations. Now, we all know that MRI is the gold standard at defining a specific lumbar disc herniation lesion. But when a patient comes into the office, there are some clues from the history and the exam that can guide you in that direction and make a tentative diagnosis more concise. Number one is the pain pattern. Lumbar disc herniations, more times than not, are going to involve leg pain. And the leg pain is usually going to be on one side, and it's going to be below the knee. The second thing that you're going to look for with a herniation is going to be pain with sitting, pain with driving, pain with bending over. And those activities are normally going to make the extremity pain worse. If there is a disc bulge or an aggravation of the disc fibers, but not a frank herniation, you're less likely for those activities to create leg pain. The second thing you want to look for in the objective status is which tests are going to be best suited based on evidence-based research to point you in the diagnosis of a lumbar disc herniation versus just a disc irritation. And the two that really stick out are going to be the slump test and the SLR test. Both of those together have a fairly high amount of efficacy at realizing when those are positive that you're dealing with some kind of a disc lesion. But when they're both positive together and they reproduce the leg pain, then that is a very high measure that you're dealing with a disc herniation instead of just a disc bulge or a lumbar strain of the muscles. So the other thing to look for is you can have a lumbar disc herniation that is producing radicular pain down one leg past the knee, but you don't necessarily have a lumbar radiculopathy. In order to have a lumbar radiculopathy, you need to have a neuromotor deficit, which would include a loss of sensation, diminished reflex, or some weakening of the muscular system on the dermatome that you're testing. If you don't have that, you're probably dealing with potentially low back pain with sciatica coming from a disc herniation, but you may not be dealing with a lumbar radiculopathy. And I see that oftentimes on peer reviews where lumbar radiculopathy is used and there's no neuromotor deficit, which is critical that you have that in there. The last thing is we all as practitioners need to be aware of red flags that can come in along with leg pain. So if someone comes in with leg pain and there's significant weakness, that would be a possible indication that you may want to get imaging to make sure you're not dealing with a more serious compression of the nerve, such as cauda equina syndrome. Other questions to ask: is there any genital numbness, or is there any change in bowel or bladder control? If someone has problems fully emptying their bladder, those are more medical emergencies. So it's not going to happen very often, but if someone comes in with leg pain, you need to make sure that there's no change in bowel or bladder control, no genital numbness, and there is no significant weakness. Those are indications that an MRI should be done before treatment is initiated. If the red flag signs are not there, you can treat them and go under a trial of care, keeping a close watch to make sure those neurological signs aren't getting worse. So these tests will help you tentatively diagnose a disc herniation, which is more commonly producing leg pain. If the patient doesn't respond to care, then the next step, of course, would be an MRI. So I hope this help desk episode was helpful, and look for more tips and clinical pearls as time goes on. Thanks.